My name is Lorenzo Leggio. I'm a physician and scientist at the NIAAA and NIDA at the National Institute of Health in Bethesda, Maryland. I'm here at the International Liver Conference in Vienna, and today I'm going to talk in a symposium on alcoholic liver disease. It's a very interesting symposium, and I'm very happy that the ESL Society is hosting a specific topic on alcoholic liver disease. And the reason is because alcohol is in fact one of the leading causes of mortality and morbidity in the world, and is one of the main etiologies for liver damage. Indeed, with the upcoming new therapies for HCV, we predict that alcohol is going to be one, if not the most frequent reason for liver damage in the world. My symposium, actually my talk more specifically, is going to focus on the bridge between the liver and the brain, because it's true that when we have a patient with alcoholic liver disease, we want to treat the liver damage. But on the other hand, it's very important to treat the underlying etiology, which is excessive alcohol use. So my research in particular at NIH is focused on the development of new medications to treat alcohol use disorder. In general, we want to help patients to reduce drinking, to stop drinking. And in the past, treatments for alcohol dependence were primarily behavioral treatments. However, in the past 2 decades, there has been an increasing body of literature helping us to understand how alcohol-seeking behaviors, such as alcohol craving, alcohol drinking work. So now we can target these neurobiological pathways with medications, and indeed we do have medications that combined with behavior treatments may help people to reduce drinking, to stop drinking, and to prevent a relapse. There are indeed some medications approved in Europe as well as in the United States for alcohol dependence. Some of these medications are, for example, naltrexone, acamprosate, disulfiram. There is also a new medication called nalmefene, which has been approved in Europe but not in the United States. There is, for example, a recent meta-analysis in JAMA by a group at the University of North Carolina in Chapel Hill that showed that disulfiram is not really more effective than placebo. There is no meta-analytical evidence for disulfiram, but by contrast, naltrexone and acamprosate do work. They help reducing drinking in patients with alcohol use disorder. So the good news is that we do have medications that the physicians can prescribe to help patients to stop drinking. However, the reason why I'm here at the liver conference is because when we treat alcoholic patients with alcoholic liver disease, the problem becomes more challenging. For example, disulfiram may give liver toxicity, so it cannot be prescribed to patients with liver problems. For naltrexone, there is also a risk of liver damage, and indeed there is a contraindication to prescribe naltrexone in patients with liver problems. So we are pretty much left with one medication that can be used to treat alcohol dependence in alcoholic patients with alcoholic liver disease. And this is a sort of catch-22 if you want, because these are the patients that need the most stop drinking, but we cannot use medications to help them. So what I'm going to talk today here at the International Liver Congress is really the importance of developing medications that are effective and safe in alcoholic patients with alcoholic liver disease. And the good news is that there are medications which are not approved for alcohol dependence, they are approved for other indications, but these medications have shown efficacy in phase 2 or phase 3 trials, and also because of the pharmacology of these medications, the pharmacokinetic profile and the excretion of this medication, we think that these medications could be prescribed in this population. 3 examples are gabapentin, varenicline, and baclofen. Now, one future step is actually to formally test these medications in alcoholic patients with alcoholic liver disease. That's in particular for gabapentin and for varenicline. For baclofen is a little different because baclofen has been already tested in alcoholic patients with alcoholic liver disease. And in particular, our group a few years ago performed a clinical trial which was published on The Lancet in 2007, and in that study what we did was to specifically test this medication called baclofen in alcoholic patients with liver cirrhosis. And we found that the baclofen was safe, it also was effective in reducing drinking, in promoting alcohol abstinence, in reducing craving for alcohol, and in improving liver tests. Interesting enough, there are other studies that did not find an effect of baclofen in reducing drinking, but these studies were done in alcoholic patients without liver problems and with low severity of dependence. So what we think is that a medication like baclofen is a potentially very treatment for this specific population because baclofen seems to be particularly effective in patients with higher severity of alcohol dependence, including those alcohol-dependent patients with alcoholic liver disease. Interesting enough, we also know that patients with HCV co-infection, they have a higher severity of dependence, and of course, they have a higher degree of liver damage. And in another analysis, we found that in a very small sample of people, so in spite of having a small number in this study, baclofen was very effective in promoting alcohol abstinence in alcoholic patients with alcoholic liver disease, specifically liver cirrhosis, and HCV co-infection. So, to conclude in a way, we now understand more about the neurobiology of alcohol dependence. We can now prescribe medications, and the promise is that there are medications such as baclofen, and hopefully not just baclofen, that we could basically bridge for our labs to the real-world clinical setting, and that the physicians could prescribe in alcoholic patients, and in particular in alcoholic patients with alcoholic liver damage. Another very important piece is that while our field is really growing more and more toward development of new medications, it's equally important that the physicians eventually will prescribe these medications. So as of today, there is still some misunderstanding sometimes, meaning that some physicians are not even aware that they could prescribe medications for alcoholic patients. So another future goal is also education. On one way, it's important to develop new medications, but on the other, it's equally important to educate the future generation of physicians to make sure that they receive early on, during medical school, during training, the proper education in addiction medicine, so that they will know when they will have patients in the office with alcohol dependence and with alcoholic liver disease, that they can prescribe medications that will help patients to reduce their craving and to reduce their drinking.